So thank you, API, for giving me this opportunity. Today I'll restrict myself to something about MFLD and some newer molecules which we have into the armamentarium. So now the definitions are changing. What initially we used to call as non-alcoholic fatty liver disease, now it's turned to be MAFLD, that is metabolic dysfunction associated fatty liver disease, MASLD, metabolic dysfunction associated steatotic liver disease, and MAT-ALD, because majority of times we see this overlap, and that's metabolic and alcohol related liver disease. Because individually in our practice we all know that there's a significant overlap with metabolic and alcohol both. So for that a new terminology is metabolic and alcohol related liver disease. NFLD. So basically what NFLD consists of, it has hepatic fat accumulation that's associated with insulin resistance, steatosis of more than 5% hepatocytes. That's the key point. And we need to understand here is that the alcohol consumption should be less than 30 grams for males and 20 grams for females per day when you are labeling it as NFLD. So etiology is whenever you are labeling NFLD, you need to understand that we need to, it's a diagnosis of exclusion. So we must rule out other causes of chronic liver disease like alcohol consumption, hepatitis B, hepatitis C, drug abuse, autoimmune liver disease, hemochromatosis, and Wilson disease. And the insulin resistance and obesity are the key factors associated with this, and we have a list of endocrine disorders here. Sorry. So if you talk about globally, NFLD prevalence globally is somewhere to the tune of about 30%. In Indian setups, we have a varied presentation from 9 to 50%, but a recent meta-analysis shows that around 40% prevalence of NFLD in Indian setups. But the most surprising number is in children, NFLD is 35%, and we all are seeing now day in, day out because of the junk food, lack of exercises, and a lot of other issues. These figures are somewhat we can consider as realities. And in type 2 diabetic mellitus, NFLD prevalence is more than 50%. So this is the spectrum of liver disease. That is F0 to F3, F4 fibrosis and hepatic carcinoma. F0 fibrosis is something which we call normal liver. F0 to F1, F1 to F2 is majority of times reversible if we do proper interventions well on time. But at times when it results to F3, F4 fibrosis, it's almost an irreversible condition setting in, which we call it as cirrhosis. So this is the spectrum of liver disease. And for now, why the term is replaced? It's just a technical replacing of the terms, but MSLD replaces the old term NFLD and the new consensus definition of steatotic liver disease, which is defined as presence of excessive triglyceride storage in the liver and presence of at least one cardiometabolic risk factors. What are the cardiometabolic risk factors? We all know in metabolic syndrome, that is obesity, high triglycerides level, HDL levels, diabetic, and hypertensive. So if any two of them are present along with this, we consider it as MASLD, and so this is how the basic classification goes. So if there is any cardiometabolic disorders present, if it is present, we need to see whether alcohol consumption is there or not. If there is no alcohol consumption of significant amount, it is labeled as MASLD, and we need to do workup of MSLD. If there is a significant amount of alcohol in these patients, we consider either as MAT-ALD, or if the alcohol consumption is more than 50 grams per day, we consider it as more of alcohol-related liver diseases. And if in other causes, there are various causes like drug-induced liver disease and cryptogenic. So these are the metabolic risk factors. We all know overweight, type 2 diabetes mellitus, high triglycerides levels, HDL low, and high blood pressure levels. So if any two of them are present along with the other factors, we call it as MSLD. how to diagnosis. The most important thing which I would like to stress here is, rather than going into other part, whenever we see a patient, either who is diabetic, always see their platelet levels, always see, do complete LFT in these patients. AST, LT levels are skewed off. You need to see that there is something going on into the liver. You can see the proteins level. If your albumin globulin ratio is reversed, again you need to suspect that something is going wrong in the liver. And obviously, the first line of the first investigations for the diagnosis of NFLD would be abdominal ultrasonography, which is the initial management. And again, all of us can have a easy scoring system which is there in our mobiles, and that is FIB4 scoring system, which includes 4 things, that is AST, ALT ratio, age, and platelet counts. Just you include this 4 things in your investigation profile, and you use the calculators. If FIB4 is less than 1.35 or 1.4, you don't need to refer your patient to anybody, any hepatologist or anyone, if all other things are normal. Grossly everything is normal. You don't even need to go for elastography. If your FIB4 level is somewhere between 1.4 to 3.2, that's a gray zone where you need to have a proper diagnostic modalities. And if your FIB4 score is more than 3.25, it surely indicates, it strongly indicates that it's a case of chronic liver disease and the liver is something going wrong, which needs a proper evaluation. The next step in the evaluation, and which is now an upcoming stage, which is almost surrogate marker of liver biopsy, and that's transient elastography or fibroscan, as we all know, which is more sensitive tool than ultrasonography, and it measures the stiffness of the liver. So by that we'll be able to know what is the level of fibrosis in it. Again, for institutional purpose, MR related fibroscans which assess the quantifications of liver fat is the things, but this is obviously institutional liver related. And gold standard always is liver biopsy, because we can quantify the amount of fat inside the hepatocytes, but it's an invasive test, slightly costly test, and at times the risk of bleedings are there. So now at majority of times transient elastography is as good as liver biopsies, but when there are gray zones, obviously liver biopsy makes sense. So as I said, FIB4 score is the most important score, and if you see that if the FIB4 score is less than 1.3, then you just don't have to do anything, you don't have to worry about anything else. Now, what the basic management, અત્યાર સુધી ઘણી બધી we have encountered many drugs, many other newer molecules have come up, but the gold standard advice whenever you are seeing a patient who is having fatty liver, who is obese, the most important thing you need to tell them is lifestyle modification. Weight reduction plays key role, and we all know there is no need to stress the importance of weight reduction in this august audience. Dietary modifications, very much important. Sleep, adequate sleep should also be a part of it, and adequate mental health. All this should be the cornerstone in the initial point of advice which you all should give. We all know with around 3 to 5% reduction, the reversal of fibrosis occurs, and with 10% weight loss, there is 1 log decrease in the fatty liver score. So almost it can come down to normal with 10% weight loss. So this is most important, and dietary modifications, as I all say. But the most important point here, what I would like to stress on is that we should even advise this important thing, smoking avoidance, and in fatty liver disease patient, alcohol consumption should be strongly discouraged, and if possible, we should make them aware, we should make them learn that avoiding alcohol, even in small amount, is an important thing which will help them reduction of the fibrosis. Why I like to tell you is that in a patient who is consuming significant amount of alcohol, the usual duration of progression to cirrhosis or chronic liver disease would be 10 years. But we have seen as low as 5 to 7 years also. A young person consuming alcohol in a significant amount, and at the the span of 5 to 7 years, he might land up in cirrhosis or chronic liver disease. But for NFLD, the window is about 25 to 30 years. So if you are having NFLD, the progression to chronic liver disease or cirrhosis would be somewhere 25 to 30 years. Again, we should not be very much happy about it, because at the younger age, if you are having NFLD by about 50, there are all chances that you will end up in cirrhotics. But yes, when your patient of NFLD consumes alcohol, the transition from normal liver to chronic liver disease hastens, and it could be as fast as 10 years. So avoiding alcohol, absolute avoiding of alcohol should be strongly advised to this patient. And this is the most important thing which I would like to stress, that lifestyle modification is the most important thing. Now, there are different molecules which have been available, which have been discussed all together. If your patient is having just simple MASH, resmetirom is the drug which is approved by US FDA but still not available in India, though it's available in India, but it's from other pharmaceutical agencies. This has a significant improvement in fibrosis, especially in patients of F2, F3 fibrosis. And as we all know, right now, probably right, left and center, everybody who wants to reduce weight, they're either on semaglutide or tirzepatide. I mean, Monjaro and semaglutide and Wegovy probably is now OTC drug in a jevi halat chhe atyare to. But yes, with type 2 diabetes mellitus, we are happy that this drugs, what happens is, this drug causes weight reduction, and with weight reduction, obviously, we know that this will reduce the fatty liver part, and obviously there would be reduction in fibrosis. Then metformin, initially we all had used for that. Statins, when there is dyslipidemias, this helps in reduction of fatty livers, and when you have obesities, along obesity also, semaglutide, tirzepatide helps. And if there is significant fibrosis, obviously bariatric interventions needs to be done. So till that, what we till now knew was something that dietary modifications, lifestyle modifications were there. We didn't have any strong pharmacological agent which reversed the fibrosis. We all had used UDC at some point of time, but the major unmet need in the management of NFLD patients would be reversal of NASH and reverse liver fibrosis. Saroglitazar, PPR agonists, PPR alpha and gamma agonists like saroglitazar has been studied in Indian trials which reverses fibrosis, but still the long-term benefits are yet not known. UDCA, again, as I said, it has limited clinical benefits in treatment of NFLD and NASH, and so now there is a newer molecule which has just recently come up into the market after passing all the clinical trials, and that is NOR-UDCA, which is a slight modification of UDCA. What happens here is, because of this modification, it has an anti-proliferative, anti-fibrotic, anti-inflammatory and anti-lipotoxic properties. So what happens here is that because of cholestatic shunting, what in UDCA it happens enterohepatic shunting, here there is cholestatic shunting, and because of cholestatic shunting, NOR-UDCA has a good role as an anti-inflammatory, anti-fibrotic, anti-proliferative agents, especially when there are injured bile duct tubules. So this is a newer molecule. How there is a comparison between UDCA and NOR-UDCA. Only important point we need to understand that in UDCA goes enterohepatic circulation, so usually it is not helpful more in reduction of fibrosis. NOR-UDCA does not undergo enterohepatic circulation, it goes cholestatic circulation, and because of that it helps in reversal of fibrosis. So UDCA, probably every one of us are using UDCA day in, day out. Anytime we see SGPT, SGOT elevated, we prescribe UDCA, and we are also prescribing. I don't mind that. But again, we know that even in your acute viral hepatitis patient, this drug is not going to do any kind of wonders. what happens is it's going to settle with time only. The only approved indication of use of UDCA in clinical practice is in patients of primary biliary cirrhosis, where you need to give it in a good amount of dose, almost 15 milligram per kg per day. But now clinical trials have shown that UDCA is helpful, and it is approved in India for treatment of NFLD, and again the trials for treatment of PSC is also undergoing. So what are the dosage? The tablet strength is 500 milligram. It should be given 3 tablets together, so 1500 milligram per day. I'll be discussing some of the clinical trials. I'll just go with the clinical trials. UDCA at week 12. Usually the duration of UDCA, nor UDCA we give is for 24 weeks, but we have seen clinical benefits even at week 12, that is 3 months. I'm talking about 1500 milligram per day. And we see that AST-ALT normalization is seen almost in 90% of patients with 12 weeks of nor UDCA. The most important part, rather than AST-ALT reversal, is the reversal of fibrosis from F2 to F1, from F3 to F1, or F3 to F2. Almost 60% of cases we have seen that there is reversal of fibrosis at week 12. At week 12 and at week 24, we have seen that the reversal of fibrosis is a 1 score reduction. So F3 is reduced to F2, F2 is reduced to F1, and F1 can be reduced to F0. At 24 weeks, almost 90% of your patients has reversal of 1 score reduction in fibroscan with 1500 milligram nor UDCA per day. So again, this is the same thing, which is so it helps in reduction of AST-ALT levels and fibrosis also. I'll just go with that. Even the fibroscan scores have shown the improvement. So conclusions of Indian trial. Nor UDCA has shown significant decrease in fibrosis and improvement in liver steatosis. Nor UDCA significantly decreased AST-ALT levels, and no serious side events has been studied till now. So it seems to be a promising agent. But yes, again, in diabetics we have potent agents like semaglutide, Mounjaro and all. So these are all helpful. But again, all said and done, the most important thing which we all needs to understand is lifestyle modification is the key, and correction of your comorbidities, obesity corrections, your proper glycemic control, hypertensive control, controlling the triglyceride levels, HDL, all this, dyslipidemia, all these are the major key factors in improvement of this. So this is, and it is well safely tolerated drugs, few side effects like nausea, diarrhea, headache, and all these are things, but majority of time it is well tolerated medicines. So this is about it. Most important, it has an anti-inflammatory, anti-fibrotic, and anti-proliferative effect. So this is something about nor UDCA. Again, there are certain molecules which are still into the actions. Lilly is having a triple action molecule, probably Mounjaro karta પણ એક step આગળની molecule આવી રહી છે, resmetirom, and all these are things. Hopefully this all will help us in management of NFLD in a better way. Thank you.